Today we're going to be discussing hair replacement therapy.
Whoa. Hormone replacement therapy. Did you not get the email? HRT.
You emailed HRT, hair replacement therapy.
No. Why do you think we have an obstetrician gynecologist with us today?
Well, I don't care if it's a psychiatrist as long as it works.
No.
Fine. Hormone replacement therapy. Some of the questions I prepared may be a little bit off, but...
Okay. Sure.
I'm Dr. Paul Zalzal.
I'm Dr. Brad Weening, and our guest today,
Sandy Sharma.
Dr. Sandy Sharma is an obstetrician gynecologist at our hospital. He's been here before, done some videos for us. And today we're talking about a critical topic, one that is front of mind for so many people, hormone replacement therapy for menopause. And is it necessary? What do we do about it?
And to prepare, I went and surveyed some women to see what are the most relevant questions they have.
Okay, here we go.
And I was able to get about 4 questions before security asked me to leave the nursing break room.
For the 5th time, of course.
That's right.
What is the best time of the cycle to have the blood work done? At what point do you initiate hormone replacement therapy? Like, what symptoms can you help with it? What are the different forms of hormone replacement therapy? And what are some of the side effects of hormone replacement therapy? So hopefully we can answer some of those today.
Perfect. Yeah. Thanks, boys.
Let's start at the beginning. We're talking about menopause. So what is menopause?
That's exactly where I was going to switch.
Let's go.
The
Definition.
first question. Yeah. The first question is menopause is defined as when the ovaries stop working. So you go from puberty to menopause. At that point, the ovaries have stopped working. There's no longer going to be production of some of the essential hormones that women typically did require. So the question is when to test. Well, really, there's no need to test routinely. In fact, it's a clinical diagnosis. She stops her periods for 6 months to a year. That's when the symptomatology is really going to amplify. I typically will test people only when we're not sure what the cause of their period stopping is, and we want to make sure that it is indeed menopause, or it could be other conditions that stop the period. So it's important to check things like thyroid, prolactin, check some of the other hormones that could influence ovulation. So that's how we would define the true menopause.
Got it.
So that question's a tough one to answer, but I typically will test when I'm worried about the fact the periods have stopped.
Okay, so if it appears that it's menopause and it's fitting all the usual criteria,
Right.
the age and the patterns, then there's no real need to test.
There isn't a routine need, and using levels to justify how to treat isn't typically how we approach this.
However, if someone's super young and they stop their periods,
Test and try to figure this out. See your family doctor. They'll know what to order for what we call secondary amenorrhea, or stopping of your periods after they've initiated. And it's important to make sure you rule out all the other possibilities before embarking on a diagnosis of menopause.
So now you know your ovaries are responsible for hormone secretion that regulates your periods with the sloughing of your endometrial lining, and this is the signal that your ovaries have stopped working when you no longer have a period as a middle.
And symptoms will start to prevail, and then the question is, when do you start, right?
Yeah.
So let's talk about the symptoms.
Yeah.
What are the
so
symptoms of menopause?
women will describe as they approach menopause, and then they intensify thereafter. Hot flashes, vasomotor symptoms, we refer to them as. Hot flashes, night sweats, just the overall uncomfortable heat wave that hits.
Being
women.
irritated by your husband, is that one of the
Mood
symptoms?
changes and mood lability is absolutely part of this. And the other thing that's often underappreciated is the change in sleep pattern can be quite disruptive, because if you're not sleeping well, it flows into every aspect of your life. Your cognitive function, your sense of wellness, fatigue. You're less interested in exercising, you're less interested in a lot of things, including your sexual habits may be altered as well. And so sleep, vasomotor symptoms, and then there are other symptoms that women will describe. Changes in weight do occur.
What kind of change in weight?
Well, increasing weight, and often joint pains, muscle pains that are very non-specific.
Right.
Libido can drift downwards as well. So you've got a sort of a constellation of symptoms, and they vary quite considerably. We can have one patient in menopause right next to another, and their symptoms will be so different in terms of intensity.
Okay, now if you are someone approaching menopause and you're watching this video, you've probably turned it off now because of all the negative stuff we've been talking about. But don't worry, the whole point of this talk is to show that there is some light at the end of the tunnel, and there are some treatment options available to you.
Okay, so before we talk about treatment, my first question would be, can you just ride it out? Is there any risk to
Absolutely.
saying, listen, I don't care, I don't want to do
Absolutely.
anything, I just want to suffer through it and get through it on my own?
Now, how long
Yeah.
does that last?
Yeah.
And that's a good question. So it can last anywhere from a year to 10 years. We have patients that are, so there's 20 years outside of their menopause or transition to menopause. And so the answer is you can make changes. And the changes would include eating well, where you're actually eating healthier, avoiding triggers for hot flashes, caffeine and alcohol, especially red wine, which unfortunately is not particularly an easy thing to give up for some people.
Yep.
And exercise, because exercise does release endorphins, exercise lets you sleep better, exercise maintains other aspects of your health.
Is it red wine only or white wine as well?
I think it's all alcohol, but I think there's particular types that do make it worse.
Okay.
Okay.
That being said, you can get these symptoms slightly under control, but if a woman's extremely symptomatic, then we have to talk about what options really work. And, you know, there is no better treatment for for menopausal symptoms than hormone replacement therapy.
Okay.
And I use hormone replacement therapy. It's a bit of an older term. We actually call it menopausal hormone therapy, which is more specific.
I would have got
MHT.
confused with the hair.
Yeah, MHT won't mess you up now.
No.
But the combination of estrogen and progesterone is used. Now, I will caveat is that if a woman has had a hysterectomy, there is no recommended need to give progesterone routinely.
Okay.
So estrogen is what will be improving the symptoms of hot flashes and the sleep disturbance, vaginal dryness. But we do want to protect the uterus with the progesterone.
So do the periods resume then when you go on to hormone replacement
not
therapy?
ideally, we want to try to find a regimen that suits the patient, and not having a period is usually preferred.
Mm-hmm.
So we give it on a continuous regimen in a way that it would not cause a resumption of the menses.
And the purpose of that really is just to reduce the risk of endometrial cancer, right? So the lining is not
progesterone
left every month.
Yes, and there is some thought that it actually is also helpful in terms of counterbalancing any of the maybe it works synergistically with the bone, maybe it works synergistically to not cause an unfavorable lipid profile. That's not the main reason. It is
Okay.
for the endometrium.
Okay.
And let's talk about, the estrogen component. If someone just gets estrogen, and the big concern everyone has is cancer.
Okay.
Is this going to cause cancer? And I think your question is, what
side
are the side effects? So, unfortunately, in the early 2000s, a study called the WHI came out and got a, unfortunately, press release that made it look like hormone therapy was causing all kinds of cancers. There was a lot of flaws with the study. Unfortunately, the media ran with it without proper, peer-reviewed editorials and peer-reviewed comments to justify the outcomes. So I will summarize it really quickly, but for starters, they were an older population, women in their 60s starting hormone replacement therapy.
Okay.
The ideal time, going to your question, is it is still going to be the best time to do it within the first 5 to 10 years of the final menstrual period.
Okay.
That is the most symptomatic period, but it's also an interval where hundreds of studies have shown that it is extremely safe. So the risk of breast cancer increase in the initial first few years after menopause isn't there.
And this is the cancer that we're talking about. It's breast cancer.
It is absolutely breast cancer specifically. And then even if we took the WHI study, which was not particularly well done.
Why? WHI. No, WHI. Why?
Yeah, exactly. That's Women's Health Initiative.
Right.
When we looked at the risk of breast cancer in the users of hormone therapy, it was 38 per 10,000.
Okay.
We took the risk in non-users was 30 in 10,000. So they were almost identical. And that was in a poorly chosen population of an older group of women who already have an increased risk based on age alone.
Right.
When we take the 50 to 55 or 50 to 60-year-old group, and we also apply the current regimens that we're using, we don't see that risk. And the current regimen is to use sort of a more bioidentical approach, but a prescribed Health Canada FDA-approved type of products that have safety and dosing.
Okay, I think that's a really important point. So early initiation of menopausal hormone replacement in the first 5 to 10 years after menses ceases does not have an increased risk of breast cancer
Correct.
associated with it based on
Just
modern
the hormone therapy alone.
Yeah, modern hormone therapy regimens and based on the literature available to us. Is that fair to say?
Yeah, I mean, there are
that's a
other
good
factors
bottom
that are going to
line.
influence
Yeah,
this.
absolutely.
Exactly. So breast cancer has other factors that are
Yeah.
contributors along with just random disease. So the hormone therapy itself is equivalent to, that risk of alcohol consumption and cancer increased risk.
Right.
Okay.
specifically with respect to breast cancer, what about people that have specific types of breast cancer? So like BRCA1 or BRCA2 or estrogen sensitive breast cancers?
So actually, if you are a carrier, you still could take it, although it's not particularly robustly accepted.
Right.
That being said, if there's a family history that someone's come to me and they say that my mom had breast cancer or my aunt had breast cancer, that does not mean that person cannot have hormone replacement therapy. And I will also clarify that any of the cancers that we typically see on HRT or MHT have a higher survivability and curability rate. So it's probably early detection and also less aggressive types as well.
Okay.
And then getting back to the types, I do think it's an important concept because we can give estrogen in the form of estradiol in various forms. A tablet, we can use transdermal, which is available as a patch, or it can be available as a lotion or gel type of delivery system. With respect to the progesterone, typically it's an oral micronized progesterone that is the most accepted and probably the best on the market currently. Buyer beware if patients start to go into the bioidentical, non-typically FDA or Health Canada prescribed products, then you start getting into quite variable dosing, variable responses, and unfortunately variable success.
Like more the nutraceutical kind of side of things.
Yeah, so what's happened, and the trend has been because primary care physicians have really gotten afraid of hormone therapy, patients will often seek other healthcare providers that are maybe alternative streams, and that's creating a lot of troubles because there isn't bone density protection, which I haven't even talked about. How and for you guys,
would you? Yeah, I'm interested in the bone density protection.
So, for starters, I will be very clear: hormone therapy is not considered a first-line way of managing osteoporosis, osteopenia. So it is an adjunct or a complementary type of therapy. But in patients who do hit menopause, their bones start to decline rather rapidly, and this may be a strategy to minimize that bone decline. You gentlemen know this very well.
Yeah, osteoporosis or bone mineral density decline, osteoporosis is really the risk of fracture increases in the perimenopausal and postmenopausal period. That's why as orthopedic surgeons, we were quite interested in hormone replacement therapy. Do you know if there's a lot of evidence to support the fact that you can reduce the risk of fragility fractures once initiating HRT or MHT?
Well, we know that you maintain a better bone density, and in doing so, your fracture risks go down. And I think it is important to also look at the baseline risks as well, right? As you know, osteoporosis risks, there's a series, and again, caffeine and alcohol come up in this as well. But lifestyle, weight-bearing exercise, ethnicity plays a role, and then you add the addition of menopausal transition. Right?
Okay, so there is some theory there and common sense that would suggest that HRT would reduce the risk of fracture. Now, are you on the hormone replacements for life thereafter, or is it for a period of time after your Menzies stop?
That's a great question, and differing colleges have different recommendations. But what we can say is there really is no finite age at which you have to stop. It is based on individual risk. Most of us who prescribe hormone replacement therapy for patients in menopause or MHT will, on a regular basis, touch base with our patients before any renewals would be made to reevaluate their individual risk. And to me, the individual risk is cardiovascular disease. Have they had a stroke? MI? Is their lipid profile getting poorly managed? Have they developed poorly controlled diabetes? And I will just go back to diabetes. Actually, if you take hormone therapy in the first 5 to 10 years of menopause, we actually saw lower type 2 diabetes. And that's actually an important fact. But so if the patient's still suitable to continue on, we will renew it. And also, I will often have a conversation about, would you like to come off and see how you feel? A significant portion of patients will have resumption of the symptoms they were trying to treat, but there are patients, 3 to 5, 10 years out that come off and they're fine. And part of it probably has to do with the receptors downregulating and their needs drop off and the symptomatology changes.
Lastly, just about the risks and benefits, and you brought it up, the cardiovascular risk. So if someone has had a stroke or has had a heart attack, we know that estrogen has been associated with things like that and things like blood clots. What are the guidelines currently for those people?
So,
obviously individualized.
For starters, it's not a preventive strategy. So for example, if someone has heart disease, we used to think that being on hormone therapy was a preventative thing, or someone has So primary and secondary prevention has never been demonstrated, really. So if someone has a stroke or any type of cardiovascular event of significance, I would take them off the hormone therapy, end of story, because I think their risk benefits aren't really justified there.
Yep.
I think if someone has well-controlled hypertension, someone has well-controlled cholesterol that's they're on a statin, I think it's quite a reasonable way to manage these patients.
Yep.
So let's talk about the VTE or the blood clot risk. So it's irrefutable that these compounds, specifically the estrogen compound, does increase the risk of a venous thromboembolism, and it tends to be with the initiation of the therapy.
Okay.
It is very similar to a birth control pill risk, but maybe not to the same magnitude. But regardless, that is an accepted risk, but it is a low risk above baseline.
Yep.
It does diminish over time, but never drops down to zero risk. There is some thought that using transdermal approach or skin absorbed routes has a lower risk of certain events, including stroke and VTE, and we think that may be a benefit, which is why it has become quite popular as a way of prescribing.
And the risk of DVT is important for us because when we perform hip replacement or knee replacement or many orthopedic procedures, the risk of DVT is there. So it's important for us to recognize if we're on something that increases the risk. And now I think for those of us who've been watching our show for a while, I think you know that any treatment has a risk and a benefit associated with it. And we call that the risk-benefit profile. Everything from taking an aspirin a day has risks associated with some benefits to hormone replacement therapy. So you really want to have this discussion with your healthcare provider to determine if the risk-benefit ratio is tipped in your favor to initiate this kind of treatment.
Absolutely. And there's one more thing I do want to bring up, because
absolutely.
one of the topics we didn't talk about that hits women in menopause is the vaginal dryness, painful intercourse.
Okay.
And that's often not talked about enough. And as gynecologists, we do see our patients silently suffering from this. And if that's the only symptom the woman has in menopause, that is a very simple problem to fix with local estrogen therapy in the form of either cream, absorbed tablet, or a slow release ring vaginally that would remedy those symptoms. And it is extremely safe, so you don't need to take a progesterone with that type of therapy. You can use it indefinitely. It's safe enough that you could even use it in someone who's had a cancer if you wanted to, but again, is
there systemic absorption with that?
No, that's the beauty of it. It is extremely safe there, and it's extremely effective, and it can be life-altering for people's relationships as well.
And these can be tricky conversations with your doctor sometimes, regardless.
It is important. I mean, the family doctors, I would say, really, I think they get overwhelmed with the conversation about what to do with these symptoms and whether they feel comfortable prescribing hormone therapy. And so I think when patients don't feel like they have that confidence, they may not take the product, and that's why we need to help educate and re-educate again that it's a safe option.
Thanks for bringing that up, because that's the point of this channel. For things you might not feel comfortable talking to your healthcare provider about, you can. This might give you some confidence to do so, because we just try and normalize any symptom you have or any complaint you have or anything that you have, that you can bring it to your healthcare provider.
Awesome summary.
Yeah, I would like to summarize what you said, but it was just too much. Just rewind it and watch it again.
And most importantly, the take-home message is that if you are suffering symptoms of menopause, regardless of what they are, there are options. Talk to your doctor. There are very successful, safe treatments. And if you like this video, please like and subscribe to our channel. Leave a comment about your experience with hormone replacement therapy or menopause in general.
Yeah, talk to your doctor. We just did.
Yeah.
Remember, you are in charge of your own health. Last question. Does the transplanted hair fall out like the... Oh, sorry, that was for the other topic. Never mind.
We'll see you next time, and thanks to Dr. Sharma for joining us.
Thanks, guys.